Welcome to the deep dive. Today we're tackling priapism, that condition you might have heard about, possibly in hushed tones,
Right.
but it's a serious medical issue. A prolonged, often painful erection, completely separate from, well, sexual desire.
Exactly.
So our goal in this deep dive is simple. Give you a clear, concise, high-yield understanding of priapism, specifically for your revision. We know you want the essential knowledge and efficiently. So let's just jump right in.
Okay, so priapism, fundamentally, it's a persistent penile erection, and the key time frame is it lasts for more than 4 hours, and it's not caused by sexual stimulation.
4 hours. Got it.
And there are two main types you really need to know. Ischemic, which we sometimes call low flow,
Low flow, right?
and non-ischemic or high flow priapism.
Low flow and high flow. Okay, those names seem fairly clear, but what's the core difference happening in the body? What should we be picturing?
That's a really good point. For ischemic, the crucial thing is reduced vascular outflow from the penis. Yeah. Think of it like a major traffic jam. Deoxygenated blood is basically stuck. It can't leave. And that leads to this buildup of oxygen-poor blood.
Okay, a traffic jam, blood can't get out. Makes sense. What about non-ischemic then, the high flow one?
Right, so non-ischemic is pretty much the opposite problem. It's about high arterial inflow of blood.
Too much coming in.
Exactly, like a tap jammed in the on position. It's constantly pumping oxygenated blood into the penis. And often, this is because of an abnormal connection, what we call a fistula, maybe after trauma.
A stuck tap versus a traffic jam. Okay, I can visualize that. But where do these problems, these traffic jams and stuck taps, actually come from? What are the underlying causes we should remember for revision?
Well, the causes are quite diverse, actually. Sometimes we just don't know why it happened. That's what we call idiopathic.
Right, unknown.
But often, priapism is linked to other conditions. Ischemic priapism is usually because of some kind of impairment in the blood flow out of the penis.
The outflow problem again.
Yes. Whereas non-ischemic, like we said, typically results from arterial issues or, some form of trauma.
Okay.
What's really striking is just the sheer range of potential triggers. You've got blood disorders like sickle cell, certain medications, even recreational drugs.
So it's not just one thing.
Not at all. It really highlights how something that seems quite localized can actually be a sign of broader systemic issues or even lifestyle factors.
That's important. So are there specific things that make someone more likely to experience this? What are the key risk factors we should keep in mind?
Yes, and there's definitely quite a bit of overlap with the causes, which can actually help with remembering them.
Good point.
Key risk factors to note include having sickle cell disease or other blood disorders. These can really mess with blood flow.
Right, sickle cell keeps coming up.
It's a big one. Also, certain medications, particularly some erectile dysfunction drugs, especially the ones injected directly into the penis.
Intracavernosal ones.
Exactly. And anticoagulants, they can also increase the risk. Trauma to the genital area is another factor, and substance abuse, cocaine use especially.
Yeah. Okay.
And we also see a slightly higher risk in people with leukemia or other cancers affecting the blood.
Right. Now, let's maybe dig a bit deeper into the mechanics. How does this actually work physiologically for both types? What's the underlying pathophysiology that we need to grasp?
Okay, so for ischemic priapism, it all starts with that restricted blood flow, the outflow problem.
The traffic jam.
The traffic jam, yes. This leads pretty quickly to hypoxia, which is low oxygen levels in the tissues.
Okay.
And then ischemia, which means not enough blood supply getting to the penile tissue itself. And that restriction might be caused by, say, a blood clot or the veins getting compressed, or maybe the normal mechanisms that regulate erections just aren't working right.
So the traffic jam stops fresh, oxygenated blood getting in, and the old stuff can't get out.
Precisely. That analogy really holds up.
Okay, that's clear for ischemic. How does non-ischemic differ physiologically? What should we picture there?
So in non-ischemic, the key mechanism is an abnormal sort of shunting of arterial blood directly into the erectile tissues.
Shunting. Like a shortcut.
Kind of, yeah. It results in a persistent erection, and this is the crucial difference, it happens without the blockage of veins or the tissue oxygen deprivation, the hypoxia that you see in the ischemic type.
Ah, so the blood flowing in is still oxygenated.
Yes, exactly. It's just flowing into the penis in an unregulated, excessive way. The tap is stuck open, but the drain isn't blocked initially.
Got it. Big difference in terms of tissue damage risk, then, I imagine.
Huge difference.
So if someone actually presents with a prolonged erection, what else could be going on? What other conditions should we think about, to differentiate them from priapism? the differentials.
Absolutely critical question for revision. You definitely need to consider the differential diagnosis. I mean, the most obvious thing to rule out is just normal sexual arousal causing an erection.
Right, but that would be linked to stimulation.
Exactly, and it resolves afterwards. Then there's something called paraphimosis. That's where the foreskin gets trapped behind the head of the penis and causes swelling. But remember, that's an anatomical issue with the foreskin, not really an erection of the penile shaft itself.
Different location of the problem.
Right. Penile fractures are another one, usually involve obvious acute trauma and a lot of pain focused at the fracture site.
Okay.
And finally, maybe penile hematomas. Again, typically after trauma, presenting with localized swelling and bruising, like a bad bruise. Keeping these distinctions clear is really important.
Okay, those are definitely key differences. Now, stepping back a bit, thinking bigger picture, how common is this? What does the epidemiology tell us that we should know?
Well, the data, especially solid UK data, has some limitations, but we do know priapism can happen in males of basically all ages, including children.
Even kids, okay.
Yeah. Interestingly, there's a higher occurrence noted in individuals of African or African-Caribbean descent.
And that links back to sickle cell.
Largely, yes, due to the higher prevalence of sickle cell disease in those populations. Another interesting point is a sort of bimodal age distribution.
Bimodal, meaning two peaks.
Exactly. There are peaks in younger boys, often in between 5 and 10 years old.
Wow, that young.
And then again in men between about 20 and 50 years old. It's quite an unexpected pattern, really. It raises interesting questions about maybe different predominant causes in those age groups.
That is surprising, worth remembering. Any idea of the overall incidence?
The estimated incidence is up to maybe 5.34 cases per 100,000 patient years. So not incredibly common, but common enough that you need to know about it.
Right. That bimodal distribution is definitely a detail worth tucking away. So what are the typical signs and symptoms? If someone presents, what makes you strongly suspect priapism, the key clinical features?
Okay, the absolute #1 key clinical feature, the one you must remember, is a prolonged, persistent penile erection lasting.
Over 4 hours.
Over 4 hours, yes. That is the crucial diagnostic criterion. Patients will also often have pain or discomfort in the penis. That's particularly common in ischemic priapism.
Okay, pain suggests ischemic more.
Generally, yes. It's often more painful because of the ischemia, the lack of oxygen. You might also find tenderness or swelling along the penile shaft.
Right.
Now, sometimes, though it's rarer, especially with non-ischemic priapism, the erection might actually be less painful or maybe not fully rigid.
Ah, okay.
And as we touched on with the causes, always ask about trauma. A history of trauma to the genital or perineal region might point towards a non-ischemic cause.
Good history taking is key, as always. So if you suspect priapism based on this, what are the first steps investigation-wise? What should we know?
Well, first steps are always a thorough medical history and a good physical examination. Can't skip those.
Basics first.
Absolutely. After that, blood tests become pretty vital. We need to check for underlying conditions, like running a sickle cell screen if relevant. And we'll also very frequently do a blood gas analysis. But this is special. It's blood taken directly from the penis, from the corpora cavernosa.
Right, to check the oxygen levels in there.
Exactly, to assess its oxygenation status directly. Imaging can also be really helpful, particularly a Doppler ultrasound.
What did that show?
Doppler uses sound waves to visualize blood flow. It can show us how blood is moving, or not moving, through the vessels in the penis. Very useful for differentiating the types.
Okay. Are there any more detailed investigations that really help pin down the type and maybe the cause? What else do we need to know about?
Yeah, definitely. A full blood count is standard, helps look for infection, anemia, leukemia maybe. A toxicology screen is often done too, looking for those recreational drugs we mentioned.
Right, cocaine, etc.
But probably the most direct way to differentiate between ischemic and non-ischemic is that cavernosal blood gas analysis we mentioned.
The blood gas from the penis itself. What do the results tell you?
So, in ischemic priapism, remember the blood is trapped and deoxygenated, the traffic jam. So you'll find reduced PO2, that's the partial pressure of oxygen, it'll be low. The pH will also be low, meaning it's acidic. And the PCO2, the carbon dioxide level, will be high.
Low oxygen, low pH, high CO2. Stagnant blood.
Exactly. Think stagnant, oxygen-poor blood. That pattern is classic for ischemic.
And non-ischemic would look different.
It should look more like normal arterial blood, higher oxygen, normal pH, lower CO2, because the blood is still flowing and, well, just too much of it. The Doppler ultrasound is another good way to check flow patterns if maybe the blood gas isn't done or is unclear.
Okay, but the main diagnosis is still clinical first.
Primarily clinical, yes, based on that history and the 4-hour erection. The investigations really help categorize the type ischemic versus non-ischemic and identify potential underlying causes.
Right, makes sense. Okay, we've covered definition, causes, how it works, diagnosis. Now, the really practical bit. How do we actually manage priapism? What's the approach we need to understand for revision?
Okay, management. The main goals are pretty straightforward. 1, relieve the prolonged erection. 2, try to preserve future erectile function as much as possible. And 3, address whatever underlying cause might be there.
Resolve, preserve, address. Got it.
Now, the strategies are very different depending on the type. Ischemic priapism, and this is crucial, is a medical emergency.
Emergency. Needs immediate treatment.
Absolutely. Time is tissue. The approach is usually stepwise. First, we try aspiration. That means using a needle and syringe to drain the old trapped blood out of the corpora cavernosa.
Just drain it out.
Yeah, often followed by flushing the area with some saline. If aspiration alone doesn't work, the next step is usually injecting a vasoconstricting medication directly into the penis.
Like phenylephrine.
Phenylephrine is the common one, yes. The idea is to chemically constrict the blood vessels to reduce inflow and allow outflow.
Okay, and if that doesn't work?
Then surgical options have to be considered, usually creating some kind of shunt to divert the blood flow, but that's generally if the less invasive methods fail.
Okay, so ischemic, emergency, aspiration, then injection, then maybe surgery. How is non-ischemic managed? Is it the same urgency?
Not at all. That's a key distinction to remember. Because there isn't that immediate tissue hypoxia, non-ischemic priapism is generally not considered an emergency.
Okay, much less urgent. So what do?
Often the first-line approach is actually just observation.
Really? Just wait and see?
Yeah, because it can sometimes resolve spontaneously on its own over time. If it persists or is bothersome, other options like selective arterial embolization might be considered, but watchful waiting is often initial management.
Wow, quite a contrast in approach.
Right.
So thinking long-term then, what's the outlook for patients? What's the prognosis we should be aware of?
It really varies. Depends heavily on the type of priapism, how long it lasted, especially for ischemic, and the underlying cause. But the big message, as we've said, is that prompt treatment for ischemic priapism is absolutely key for a better outcome.
Right, because of the tissue damage risk.
Exactly. In ischemic cases, if treatment is delayed, there's a significant risk of permanent damage to the penile tissue, fibrosis, scarring,
Which leads to?
which can lead to long-term erectile dysfunction. That's the major concern.
Okay, and for non-ischemic?
Generally, a much more favorable prognosis. Because there isn't that initial ischemic injury, the risk of long-term complications like ED is much lower.
So overall, manage ischemic quickly, non-ischemic has a better outlook anyway.
That's a good summary. Early, appropriate management is crucial, especially for ischemic, and non-ischemic tends to do better long-term.
Okay. And what are the specific potential complications if things don't go well or if it's a severe case?
Yeah.
What should we be mindful of?
Well, the most significant complication, the one we worry most about after prolonged ischemic priapism, is erectile dysfunction.
Right, ED.
We can also see fibrosis or scarring of the penile tissue, which contributes to ED but can also cause penile curvature or shortening. Some individuals might suffer from recurrent episodes of priapism, which can be really distressing.
I can imagine.
And we shouldn't forget the psychological impact either. This can cause significant distress, anxiety, relationship issues.
Yeah, the psychosocial aspect is important too.
Definitely. And finally, there are potential complications related to the treatments themselves, things like infection from injections or aspiration, bleeding, or complications from surgery if it's needed.
Okay, quite a list to be aware of. This has been incredibly thorough, really helpful. Now, to help all this stick for revision, do you have any memory aids, mnemonics, basically example questions?
Absolutely. Let's try a couple. For telling the types apart, for ischemic priapism, think outflow blocked, oxygen low. That hits the venous obstruction and the resulting hypoxia.
Outflow blocked, oxygen low. Okay, I like that.
And for non-ischemic, maybe think inflow high, no O2 low initially. Emphasizes the high arterial flow without that immediate oxygen problem.
Inflow high, no O2 low initially. Okay, those are really handy.
Glad they help. Now, how about a sample MSRA style question for you listening? A 30-year-old man, known to have sickle cell trait, presents to the emergency department. He's had a painful erection for the past 5 hours. You aspirate blood from the penis. It's dark, viscous. The blood gas shows PO2 of 35 millimillijar, pH of 7.0, and PCO2 of 60 millimilli-Hg. What's the most likely diagnosis?
Okay, 5 hours, painful sickle cell trait, and those best numbers. Low oxygen, low pH, high CO2. So that sounds exactly like
Ischemic priapism.
ischemic priapism, right, based on the duration, the pain, and those classic blood gas results.
Exactly. Okay, another one. What's the first-line treatment for ischemic priapism?
Aspiration. Draining the blood.
Spot on. Aspiration of blood from the corpora cavernosa. Now flip it. A 25-year-old man presents with a non-painful, partially rigid erection. It started after he sustained blunt perineal trauma playing football yesterday. What's the most likely initial management approach?
Okay, non-painful, trauma-related, not fully rigid. Sounds non-ischemic, so you said observation.
Observation is often the first step, yes. Watchful waiting. So, a key memory tip overall. Always focus on the duration of the erection. That 4-hour threshold is critical. And really understand that fundamental difference in blood flow and tissue oxygenation between ischemic and non-ischemic.
Fantastic. Those examples really drive the points home. So just to quickly recap for everyone listening, we've gone through the definition of priapism, the vital difference between ischemic, low flow, emergency, and non-ischemic, high flow, less urgent types. We covered causes, risk factors like sickle cell, the pathophysiology, traffic jams versus stuck taps, how to differentiate it from other things, who's most at risk, the typical presentation, how we investigate using things like cavernosal blood gas and Doppler, the very different treatment approaches, potential outcomes, and the complications like ED, and crucially, that message about rapid management for ischemic priapism being absolutely essential.
Exactly. Hopefully this deep dive has really given you a clear, high-yield overview of priapism, ready for your revision. We hope you feel much better equipped now to understand this important condition.
Definitely. And on that note, if you are looking for more resources to help with your MSRA preparation, don't forget to check out passthemsra.com.
And freemsra.com for free questions, too.
Great resources.
And maybe a final thought to leave you with. Consider how conditions like priapism, which seem very localized, can actually have really significant systemic implications, especially when they're linked to underlying diseases like sickle cell. It really underscores why understanding that basic pathophysiology is so critical for guiding urgent management decisions.
A really important point. Thanks for breaking that all down today.
My pleasure. Thanks for exploring it with us.